Hi everyone, and welcome to tonight's webinar on Dementia Demystified. And my name is Pete Silberberg, and joining me is my colleague and friend Beck Moore. And we're joining you on behalf of Dementia Training Australia and FACE. And we're very excited to give you this webinar tonight. Now, just a few things we need to remind you of. If you haven't already done, can you please put your name, your first and your last name in your attendee section on the Zoom, because we need to record who is at the meeting tonight. Okay, so let's get going. So first of all, we'd like to make an acknowledgement of country. So DTA would like to show our respect and acknowledge the traditional custodians of the lands that we're all sitting on tonight. I'm sitting on Bundjalung Nation up on the north coast of New South Wales. And I'll extend our respect to elders past, present and emerging, and to all Aboriginal people, especially anyone who's attending the meeting tonight. And we also pay respect to Aboriginal and Torres Strait Islander people living with dementia and their carers. So we do have the Q&A window open tonight. So, sorry, the chat window open. So if you'd like to ask us a question during the webinar, then please do, because Beck and I are happy to take questions. And Beck,
we like questions.
What's that? We love questions. Yeah. So just
we like questions.
We like questions. Just before we get going, tell the participants a little bit about yourself.
So my name's Rebecca Moore. I'm a GP. I work currently at Redhead Surgery, which is in Newcastle. I'm on Awabakal land tonight. I have a special interest in geriatric medicine and in particular in dementia, and I've just completed my master's degree of dementia through the University of Tasmania, and I work for Dementia Training Australia.
Fantastic. I work up in the north coast of New South Wales. I'm a GP and a GP supervisor looking after registrars and medical students and all that jazz. And I also work as a medical educator for Dementia Training Australia. I'm in two general practices, a mainstream general practice, which would be sort of regional on the coast here, and also the lead clinician at an Aboriginal medical service in Lismore. So by attending this webinar tonight, we hope you'll be able to recognise the features of dementia and cognitive impairment and explain the trajectory of dementia and cognitive impairment. And we're going to introduce some frameworks to help you understand dementia better and particularly make a diagnosis of Alzheimer's dementia. And we always like to begin with the end in mind, or the take-home messages. So dementia is more than a memory problem, isn't it, Beck? It's it involves all parts of cognition, and that's the first one, and we're going to go over that in more detail shortly. The second one is that cognitive assessment tools are not diagnostic tools. So a cognitive assessment tool is something like a mini mental state examination, and they're not diagnostic because if you score below the cutoff, say you get a score of 23 below the cutoff of 25, that does not make a diagnosis of dementia. They are helpful, and we'll explain how you use them in this practice, but they're not diagnostic. And we really want to stress tonight that in many situations, you as the GP of the people that you're seeing, you're ideally placed to diagnose and manage dementia. So Beck, language is really important in this work, isn't it?
Absolutely. And we strongly encourage you to have a look at the dementia language guidelines. You can find them on the Dementia Australia website, and there's a link there too. I think it's increasingly evident that that people who are living with dementia, particularly those of younger onset, have been quite vocal in stating the importance of language when a person comes to you and they're given a diagnosis of dementia, suddenly everything changes for them, and it can be a really frightening time for them. It's very important that we try and maintain that personhood and that dignity, and make sure that we use respectful language, language that's empowering, language that's inclusive, because the person doesn't go from one person 1 minute to a different person the next. They remain the same. So we try and refer to people as people living with dementia, not people with dementia, and certainly not people who are dementing. And similarly, when it comes to behaviours, we talk about changed behaviours, and we talk about expressions of unmet need, being accurate in explaining what the behaviour is.
Thanks,
Yeah,
Beck.
I think it's worth keeping an eye.
Yeah, that's right. I'm sure people do this all the time already. So just in the same vein that you were probably taught when you're doing mental health terms, it's a person living with schizophrenia. It's not a schizophrenic. And it's the same in dementia. Yeah, it's really important that we use respectful language in that sense. So we thought it's important to start with a broad definition to give you an understanding of dementia, because dementia is a syndrome, which means it's sort of a collection of symptoms that brought together signifies a potential issue. So we're going to go through this slowly, and each part's going to give you a bit of an idea to understand what dementia is in more detail. So the first thing is dementia is progressive. So what do we mean by progressive, Beck?
In the sense that it gets worse.
Gets worse over time. Yep.
Yeah.
Unlike some other illnesses that do remain static. So it's global. So what are we talking about there?
Well, essentially, we're talking about the fact that the whole of the brain in time becomes affected. And also there's the other aspect of the fact that dementia is a global world problem as well.
Double meaning. Excellent.
Double meaning.
Double meaning. And life-limiting condition also has a double meaning, doesn't it?
Absolutely. I mean, I think one of the things that, I think many of us don't realise is that dementia is actually a terminal condition, and that people will potentially die from their dementia. And it's life limiting in the sense that it also does limit somebody's ability to perform certain functions and activities of daily living as well.
Yeah, so it's progressive, it gets worse over time, and it affects the whole brain, and it's life limiting in both the function for the person, but also it is also a cause of death. And the illness involves what we call generalized brain degeneration, which is kind of a way of us trying to talk about the pathology, isn't it, Beck?
Yeah, absolutely. And we'll talk about that in a tick, but really, depending on the type of pathology and the location of the pathology, dementia will present differently. And that makes it quite a unique and individual condition. And again, something just worth bearing in mind, particularly when somebody comes to you with changes in cognition. It's always good to think outside the box.
Yeah, so that's covered that last point, that it does affect people in different ways because everyone thinks differently and has different ways of using their cognition, and it also has many different forms, and we're going to talk about them in a minute. The commonest one's Alzheimer's, but there are other forms as well. So just to go back over that brain degeneration, that's to signify the fact that we believe the pathology involved in dementia involves degeneration of the neurons in the brain. And the most up-to-date theory for Alzheimer's dementia is that this involves a protein called amyloid, which you've probably heard about before. So the impact of dementia in Australia and the world for that matter is very large. You might be surprised to know that it's actually the second leading cause of death overall in Australia. We talked about it being life-limiting, and it's the leading cause of death for women. And it doesn't just affect people living with dementia, but it also affects their carers as well. So it does really have a significant effect on the community, and it costs the government and us as taxpayers, I guess you think about that, a lot of money. The other thing that's not on that screen that you might be interested to know is that it disproportionately affects women over men by about 2/3 to 1/3. We're still not really quite sure why that is. There's theories abound, but no one has seemed to come up with a unifying theory. And the other one is that for those of you who are caring for Aboriginal and Torres Strait Islander people, the rates of dementia in that population are about 3 to 5 times higher than in non-Indigenous Australians. And that's probably got to do with the bigger burden of risk factors for dementia that we'll talk about as well as we move forward in this webinar. So hopefully, Beck, that's convinced people to know why we want to talk about it.
Absolutely. Now, Mark, you've put a question in the chat box. Did you want to talk to that, or would you like us to talk to that?
Look, I will if I could. Hello, everyone. I'm Mark Yates. I'm one of the geriatricians based in West Vic, PHN, and the CI for the Face Dementia project, which is all about timely diagnosis of dementia in primary care. I guess that it was really, to me, it's this idea that dementia often doesn't present at the point that there's generalized brain involvement. In fact, it often presents when there's non-generalized involvement, and that's how we define the different causes of dementia, whether it's Lewy body or Alzheimer's disease. So while late in dementia, it's generalized, early in dementia, it's often not generalized.
Thanks, Mark. That's important information. So please jump in whenever you feel the need. So this slide's about why I talk about dementia. So we talked about a bit about the incidence and how much it affects the community. And this slide's just sort of bring it back again to the person sitting in front of you. So it's extremely common, as we talked about, and it's underdiagnosed. There's research to alert us that we know that doctors in Australia, particularly GPs, struggle with diagnosing dementia, which is one of the reasons why we're doing this study. And it's not very well understood. There's still a lot of information for us to understand about the cause and the treatment of dementia, but it's also not really understood by the community and by us as clinicians. And it's not just one person's disease; it affects everyone. And it's highly likely that there are people on the webinar tonight that's had contact with dementia personally, and perhaps through their relatives or friends. And so it's really not just a medical issue, but it's a social one too. And like we talked about, it is life limiting. At the end of life, eventually the brain loses its ability to carry out functions required for living, like eating, talking, swallowing, these kind of things, and that eventually leads to death.
I mean, it is quite staggering, isn't it, Pete, to consider that it's essentially the leading cause of death in women, and it has such a vast impact in Australia. And yet, really, the amount of education that we receive during our medical training is quite limited. And Mark and I were talking before this, I think with the advent of some of the dementia medications, that concept of GPs making the diagnosis was really lost, and I think GPs became quite disempowered when that happened. And I suppose part of our role is to reinforce the fact that it is something that we see all the time in general practice, and we really need to be all over it. And so we should be able to make that diagnosis, and we should be able to help manage people when they do receive a diagnosis as well.
It is, and also it's highly enjoyable. It's really enjoyable and stimulating medicine. Like intellectually, I find this work incredibly enjoyable. It's because it's not straightforward, and that makes it more rich. But it's also just so great to be able to help people when they're faced with these problems, because when your cognition's affected, it really affects your well-being. You know, like all chronic illnesses, but really, like, think about it, it's affecting your memory and your thinking. And there's a lot of stress for the person and the family. And to be able to provide assistance is very rewarding. You find that too, Beck?
Absolutely. And I don't know if you've had this experience, but certainly I've had, when people do receive a diagnosis from a specialist and then they're sent back with very little sort of plan apart from to be reviewed again in 6 to 12 months. And so as GPs, we really are the ones that need to be able to have a bit of a capability of making these post-diagnostic management plans, etc. So yeah, I think we have a big role to play.
So we've talked about some of these barriers to diagnosis. You talked about the sort of nihilism because of lack of treatments earlier, but lack of clear diagnostic pathways. We're hopefully going to break down that barrier tonight. Diagnostic support. Well, that's an area of change, isn't it, Beck? Because there are some new potential diagnostic pathways coming down the line, aren't there?
Absolutely. I mean, I think we definitely have a lot of non-pharmacological things that we can do in terms of assisting in post-diagnostic support, and certainly on the horizon there look to be some medications that may be able to assist as well.
Yeah. So those outside ones in green are sort of about us as clinicians, and then the inside one of the barriers from patients. It is really important to think about this because people may not tell you stuff for all sorts of reasons. Now, it could be part of their cognition that they just don't have the capacity anymore to remember what they need to tell you. But it might be that it's earlier in the illness and they still have that capacity, but it's more about fear of perhaps what the information is going to mean. It might be belief systems that people have and cultural value systems around memory and thinking, or it might be that they just can't get in to see someone to talk about it. So there are all sorts of
people
barriers.
Sorry, Peter, I didn't mean to interrupt, but you know, it is also, I think, among the general population often considered to be a part of normal aging. And I think, you know, still we have to explore changes in cognition when someone comes in, because often their family will just say, oh, he's just getting old. But in fact, it is an underlying dementia diagnosis.
Yeah, and so hopefully we've also convinced you of this already, that the benefits are massive for the person in front of you and for their family and carers. But it's also really helpful for you because it can suddenly make sense about the potential chaos and dysfunction that's happening for this person and their family, and no one really quite understands what's going on. Or it might be as simple as someone's diabetes management suddenly used to be good for years, and they come in for their 6-month checkup and you haven't seen them for a while, and suddenly it's gone way offline, and you're scratching your head going, why would that be? And are you still taking your medication? Yes, I'm taking your medication. And then you ring the pharmacy and you know, they were getting Webster packs, and in fact, you know, they're running a week late every month, so they're only having 3 weeks of their 4 weeks of tablets, and then the penny drops, and it can all make sense. So there's an example of how it can help you too, as a clinician. So in terms of moving back to now the definition of what it is. So it's an umbrella term, isn't it, Beck? And it's used to describe multiple different forms of the same thing. So do you want to talk the participants through this slide?
Certainly, yeah. So as we say, dementia is that umbrella term for certain progressive neurodegenerative conditions that can cause impairment of brain function. So in the blue section, we have Alzheimer's disease dementia, which constitutes between 40 and 70% of all dementia diagnoses. So that's by far the most common form of dementia that we're likely to see in general practice, followed by vascular dementia. Often you will see things that are mixed. So there's often mixed pathology. So it's very common to see somebody who has a mixed Alzheimer's and vascular picture. In our careers, we're definitely going to see people who have a Lewy body dementia or dementia associated with Parkinson's disease. And almost certainly you'll be seeing people with a frontotemporal dementia, which was formerly known as Pick's disease. So there are lots of different sorts. There's over 100 different forms of dementia. You're likely to come across alcohol-related dementia, and depending on the practice that you're in, possibly an HIV-related dementia as well. And as I said, they often will overlap with one another, but each of them has a different form of presentation. And again, that depends on the type of the pathology and the location of where the pathology is. So as Mark was saying, these things will begin in one part of the brain, and that can give us some idea of what sort of dementia it is. For example, generally with an Alzheimer's disease dementia, it's going to start to cause changes predominantly in that hippocampal complex, which is generally where memory is laid down. So often with an Alzheimer's disease dementia, one of the first things that you will notice is likely to be a change in memory, for example, but not always.
Yeah. So yeah, that's a really good summary. And just to re-emphasize that by far the majority of what you're going to see in general practice is Alzheimer's or Alzheimer's mixed vascular dementia. That accounts for sort of, up to sort of 60 to 80% of all dementias. So I said the word before about dementia syndrome. So again, that's a collection of symptoms and signs that points towards a particular thing, and that's the way we think about dementia too. And you're used to this because there are lots of things that you're doing right now that are like syndrome. So if you think about it, things like depression is a syndrome. It's a collection of symptoms without a specific diagnostic test. And you might do some scoring stuff like a DAS or a K10, and then using your clinical judgment, mainly based on history and maybe some blood tests, you come up with a diagnosis. And so dementia is pretty much the same sort of theory. So that hopefully helps give you a framework that you've used before. So rather than thinking about depression and the symptoms that you sort of ask for, now let's think about dementia. So what do you need to find? What are the inclusion criteria that you need to tick off to make a diagnosis of dementia? Well, the first one the first two are about cognition. And the two things about cognition is that they're gradual onset. In other words, it comes on slowly. And the other one is it gets worse over time. So from, over 6 to 12 months, there is a progression and a change in that cognition. So Beck, that's pretty different to some of the other sort of sudden onset cognitive changes that we might see in other illnesses, isn't it?
Yeah, absolutely. And that's where we have to look at the exclusion criteria, and we'll talk about that in a tick.
About that in a second,
yeah.
So I'll just keep going on there. So so like a sudden onset type of change in cognition that you've probably seen before might be a stroke. You think about it, it happens over minutes to hours, and there's a significant change in a person's brain function, and that is very different to a dementia, which gradually progresses over time, over months to years. It can happen a little bit faster in some of the rare forms of dementia like Lewy body, but this is predominantly about Alzheimer's dementia and vascular dementia, this talk tonight, and that does take longer, months to years. So the third thing is that change in cognition has to affect daily living, or what you might term function. And we'll talk about what those sort of things are in a bit more detail, but you have to see a difference from 12 months ago. So is there anything change for you in the last 12 months that you're doing differently? Those sorts of questions. And it might be that they can't do the banking, or they can't do the shopping, or they're driving, and these kind of activities of daily living. And then the last one is that you have to exclude everything else that could possibly be causing 1, 2, and 3, which sounds like a lot, and in some ways can be a big list, but as long as you tick them off one at a time, you will get there. Beck and I can attest to that, can't we? So let's go through these. So Beck, I'm going to get you to help me do that. So first exclusion criteria is a delirium. So tell us about that.
All right. So I suspect you've all come across delirium before, especially if you've worked in the hospital system. So delirium is a more sudden onset, acute confusion. It's characterized by fluctuations in level of cognition and in level of consciousness. And there's predominantly sort of difficulties with attention, easily distractible. And a delirium will often have associated hallucinations or some psychosis features as well. There are different types of delirium. So you have a hypoactive or a hyperactive delirium. So it may be the hypoactive one actually tends to be the one that we probably miss. That's generally when somebody's quite sleepy, sitting in the chair, fairly unobtrusive. The hyperactive delirium is much more the ones that you would have been called in the hospital for the code blacks, the people who are quite agitated with significant changes to behaviour. And of course, you can get a mixed picture too, where it fluctuates from one to the other. So
yeah, that's right.
Oh,
sorry to interrupt there, Beck, but yeah, I mean, like you said, it comes on very quickly, doesn't it? It comes on within minutes, hours to days.
Right.
Yeah.
Yeah, and there's usually a discernible cause for a delirium. I mean, classically, things like infection will be a trigger. Medication can be a trigger. Dehydration, constipation, urinary retention. There's a great myriad of things that can trigger delirium. And so it needs to be treated quickly. It essentially suggests that the brain is failing. But the importance of delirium also is that if a person has a delirium, it is they are at a greater risk of developing a dementia, or potentially people who have a dementia are at a greater risk of developing a delirium as well. And so you can't make a diagnosis of dementia when somebody has a delirium, but I would strongly recommend, if they've had a delirium in the hospital, that you put a little red flag on their notes to come back, and in 3 months or so, when things have returned to baseline, then you do some cognitive assessments to see whether perhaps they do have an underlying dementia, and continue to monitor that person as well.
Yeah, that's right. That's a good summary. And then, so moving on to the second exclusion criteria, which is basically what else could be causing this person's change in cognition. That's what we're excluding here. So here we've got alcohol and we've got other drugs. So alcohol could be acute intoxication. You can imagine, I think you all have witnessed potentially somebody not been who's had too much alcohol and is cognitively impaired, but it also could be chronic alcohol dependence, and that can eventually change cognition too. So the other one is other drugs. Now that could be drugs such as marijuana or opioids or other illicit drugs like amphetamines, but it could also be drugs that you're prescribing or that your colleagues are prescribing, particularly the class of drugs which are called the anticholinergic drugs, like the tricyclic antidepressants like NDEP, or some of the drugs we use to stabilize bladder control. So, but there are many, many drugs that have got just a little bit of anticholinergic effect. And if you have lots of them on board, like 4 or 5 with a little bit, then you end up with a lot. So you need to make sure that if someone's got cognitive impairment, that it's not alcohol, it's not an illicit drug, and it's not a medication that's being prescribed. And Beck, mental health disorders are another common reason for people to have change in cognition, isn't it?
Absolutely. I think that they have historically called depression a pseudo-dementia. So some people who experience depression can experience changes in their thinking, in their concentration, and can have objective changes in cognition. So certainly depression is something that we need to look for quite actively and screen for. Often mental health can be really tricky, particularly in people who already have an underlying diagnosis of a psychotic sort of illness. So people who have underlying diagnoses of bipolar disorder or schizophrenia can sometimes really make it very difficult to discern whether it's that's the problem or whether they are developing a dementia as well. And so these people are certainly ones that we would recommend asking the specialists to see, because also, as we've said, dementia can present with changes in thinking. So you can get hallucinations, you can get visual hallucinations, you can get delusional thoughts. So sometimes there is a crossover there as well.
That's right.
The other thing is, yeah.
Go on.
Oh, sorry, I was just going to say, Pete, I've certainly made this mistake several times now, in having people present as quite anxious and thinking that they have an anxiety, but in fact, it's probably been a prodrome of a dementia disorder. So again, that's something just to be mindful of, that sometimes there are mental health conditions that form part of a dementia, but yeah, it's sometimes quite tricky to tease out. So firstly,
yeah, that's right. And of course, you can have two things going on at the same time, which can make it a bit hard too. So the last one is other organic disorders. So, typically we're going to, people talk about, B12 deficiency, or maybe an intracranial bleed or an intracranial mass, and these kind of things. The way I think about it a little bit differently now with other organic disorders, I think about it more as sort of chronic disease load. So I know that when I'm working at my Aboriginal medical service, where chronic diseases are more common, that the teasing out causes of cognitive impairment when there's long-standing diabetes, long-standing heart disease, long-standing trauma, maybe some long-standing sort of alcohol dependency or other drug dependency. The list just gets quite long in terms of like what could be the cause of the cognitive changes. So, those people that are quite complex in that sense also can be really helpful to reach out to your colleagues like Mark to get some advice. I know I certainly do. I love the chat, by the way.
And I think the thing is, Biden.
About Biden, yeah, good. Maybe at the end we'll try and diagnose what Biden's got, but I think Mark's had a go already. Sorry, Beth, you're going to add something?
Oh, I was just going to say, the thing about the exclusion criteria is you basically need to make sure that you've treated them and things are as good as at baseline as can be. And once you've done that, then you go back and you reassess for dementia using your history and your cognitive assessment tools.
Yeah, and your inclusion criteria. Yeah. So they're your inclusion criteria: gradual onset of progressive change in cognition that also affects function. And you've excluded some other stuff, which may take a bit of time, but they don't have a delirium. There's no significant alcohol and medication and other illicit drug use on board. They don't have a significant underlying mental health disorder that could be causing their cognitive change. And you've ruled out other organic issues, largely with your investigations we'll talk about shortly. So that's the syndrome explained in inclusion and exclusion criteria. The next framework we're going to talk to you about is called the domains of dementia. So this is in recognition that we said before that affects the whole brain and the whole person. And this is a really useful framework because it gives you a framework in terms of taking a history from someone. So you can't sort of say to someone, right, well, you've presented with some memory loss. Now let's see, do you have the inclusion criteria? That obviously doesn't work. You need to be bit smoother than that. So this domains framework is a really helpful way of going through that, and it takes you through 5 domains where you can talk to someone about their cognition, their function, whether they have any mental health symptoms, alluding to whether there might be an underlying mental health disorder, whether there's some behavioural changes going on for them, and how they're going physically, because dementia can also affect you physically. So let's go through cognition first, because that's the biggie. So cognition. So we've got memory up there first, Beck, because memory is the one that everyone goes to first, because it's definitely the commoner symptom with Alzheimer's. But our take-home message was that dementia is more than memory, isn't it?
Absolutely. So, I mean, there's 2 things to that. As we're talking about, there are different cognitive domains. There are different aspects of cognition above and beyond memory, but also only about 85% of Alzheimer's disease will actually present with memory changes. So we just have to be aware and looking for the other things as well. But certainly memory is a real red flag. So if somebody comes in and you've noticed that they've missed appointments, or that their medication's not up to date, or family members have been voicing some concerns that they've been forgetting things, etc., they're red flags to go delving further into the history and look for other cognitive changes as well.
And these are the other cognitive changes. So we've got a mnemonic for you called V realms. You don't have to use this one if you don't want to, but it is might be a useful way of trying to remember everything. So why don't we take it in turn, Beck, because it's quite a long slide to do by yourself. So I'll start here with the V. So that's visual spatial. So that's a person's ability to be able to see things and interpret them in space. And so this sort of, a classic example that you're probably used to is when you're getting someone to do a clock face. So while that involves multiple areas of cognition, the visual spatial part is that they can see a two-dimensional circle and they can imagine what all the numbers look like inside that circle, and they can space them out appropriately, and then they can put a time with the minute and hour hand. And recall the memory you just talked about, Beck?
Yeah, I think it's generally short-term memory that is what we notice first to change. So and so people will often actually have quite preserved long-term memory for significant periods of time. So it's that short-term memory, the ability to lay down new memories that's affected, and usually one of the first things that we notice in Alzheimer's disease.
Yeah. And what sort of questions would you ask someone if you were asking about their memory and sort of wondering how that's going for them?
Well, I mean, I would firstly ask if they've noted any change in their memory or in their thinking, and then more specifically ask if they've missed anything recently, if they have lost anything. People are often quite candid and tell you that they've lost their car keys several times, or their relative will say, we just bought another phone because they've lost their phone again. Have they had difficulties locating the car or got lost themselves?
Repeating conversations and this writing.
That's right. Yeah.
Yeah, that's right. And particularly, has it got worse over time, or is that, I have a particular issue with remembering people's names, and I've had that for as long as I can remember. So while I might have a bit of a issue around that part of my cognition in my brain, it's not getting progressively worse. It's always been there. So that's a distinction you need to make. So executive function is about planning. So the sort of things I would say was, who in the family, plans the holidays? And if it's the person who is sitting in front of you that we're worried about, then I'd say, and how's that going? Are you still doing that? And if they say, oh no, I've given up that, that's too hard now, I've handed that over to, whoever else is sitting next to them, then that's a red flag. Or it might just be simply planning to have people around for dinner and planning what you're going to cook and how to put on a bit of a dinner party. Or it might be even planning just going out to do some shopping. So that's the way I think about executive function. And what
I think also judgment, executive function involves things like your judgment. So sometimes people or family members have concerns about safety. It seems that the person in front has been doing some strange and less safe things. Or sometimes they also don't seem to have insight into the fact that they have done that. And insight is also part of that sort of frontal lobe change. And I just wanted to talk about that whole idea of mental flexibility too. I think sometimes people can become somewhat rigid in their thinking or fixed in their thinking. And again, that's just another little red flag to delve a bit deeper. And any sort of changes to personality too. I think it's probably an opportunity at that point to, if families say, mum's quite different, she's been much more rude and irritable than she ever used to be, etc., that might be a change that we need to look into.
Well, yeah. And what about attention, Beck?
I think attention's important. It's that ability to remain focused on one thing, to concentrate, or to be able to multitask, to do more than one thing at once, and stick to task.
Yeah.
Yeah.
And language is around a few different parts. So there's dysphases, so that could be expressive or comprehending language, and agnosia is about being able to name things. And I mean, you probably see those symptoms not discommonly with people who've had strokes, especially the dysphasias. Sometimes and you can get them in dementias too. Sometimes it's a little bit more subtle. You can get what's called poverty of speech, where the richness and the quality and the amount of vocabulary used is much less. And we've got a bit of a video that might demonstrate that a little bit to you moving forward.
We've
got motor functional dyspraxia, Beck. What's that?
Yeah, so generally that's the way that we are able to sort of use tools that we understand what the tool does, and we can work it. So a classic thing that I ask about is, whether somebody has had any difficulties with the television remote or with using their phone. Certainly as a dementia progresses, there are much more obvious changes, but initially things like the telephone or the mobile phone is a really good indicator of how they're going with that.
Yeah. And then social was the last one, which you kind of touched on before, but probably the one that I look out for mainly is withdrawal. And there's lots of reasons why people don't want to go out, but so if someone's becoming withdrawn and staying at home lots, you'd probably be thinking, well, they could be depressed. That's certainly what I think. Or they might have a social anxiety. It's another common cause. But what we'd like you to add to your list tonight of differentials when that symptom is presenting is, could this be a cognitive issue, particularly in someone who's getting in a high risk age, so over 65, 75, definitely over 85. If they've suddenly been a very social person and have suddenly become much less social and don't want to go out, think, could this be a cognitive change? All right, so you've got to have a progressive change in cognition that's getting worse over time, that came on so slowly, and you need to have functional decline. They're the first three inclusion criteria. And function, we've sort of talked about these, haven't we, Beck? So let's talk about how you ask about function. What sort of questions do you ask your patients?
I think it's always, you have to delve fairly deeply sometimes into function, because you want to see if there's been a change. So has this person gone from being able to follow sort of quite elaborate recipes and put on dinner parties to being able to just reheat their light and easy? If you just ask, are you still able to, are you still cooking? And and they say yes, then you do need to explore that a little bit further. So ask what sort of work they've done in the past, and whether that's something that they're continuing to do, or if they've had any difficulties doing that sort of thing now. I think if a person is able to, like I always ask about shopping, I ask if there's been any change in the division of labour, where you have a husband and wife come in, are you still both doing what you both used to, or has one person taken over a lot of the other jobs? And I think shopping's always quite interesting, because I think if somebody has to go to the shops, they have to sort of plan. They have to plan what they're going to get. They have to plan how they're going to get there. When they're there, they have to be able to remember to get the right things, and then to get home and put it all away, and have people remember what they need, but also do they have 10 lots of toilet paper, and that sort of thing. Shopping can, I think, often give quite a lot of information, actually.
Yeah. Medication's another common one, isn't it? So remembering to take your tablets, not getting mixed up by your tablets, is a good one to check up on. And I think the top left one, sort of the digital stuff. So some most people are kind of using mobile phones these days, but some of my elderly patients are still pretty much not never really learned to use them. But even those ones, you know, have computers and use emails and that kind of stuff. So just a change in the use of digital IT technologies is one worth inquiring about.
Yeah, I had recently a pastor who used to write her own, you know,
Eulogies.
her own, yeah, and she was having real difficulties just being able to open up, you know, get to the right Word document and open it up. That was one of the first things she noticed. I had another gentleman not that long ago, and as you were talking about with the travel arrangements, it was just following timetables. He couldn't work out the timetables, and that was a real change for him, something that he used to do all the time. Yeah.
So the last three domains are on the screen there. So mental health symptoms. So we're putting that down there. So this is a bit different to someone who you're thinking about an exclusion criteria, in the sense that someone who has a dementia, a person living with dementia, may have mental health symptoms directly related to that dementia. So Beck mentioned earlier that you can have delusions and hallucinations as part of the dementia syndrome that they're presenting with, but they also may develop a reactive low mood or a reactive anxiety around what's going on for them. And so you need to ask those questions too. So yeah, partly this is to think about, could there be an exclusion clause for the change in cognition, but partly it's also to tease out whether there might be some mental health symptoms attached to a potential diagnosis. And
yeah, and I'm not sure it even necessarily is reactive. Like, I think sometimes that can inherently be a part of the dementia too, you know. I don't think they're quite sure how it all happens.
Yeah. That's true. And then behaviour changes can be significant too, can't they, Beck?
Absolutely. And I mean, generally we would start to recognize more of the behavior changes as the dementia progresses. But certainly, like you were saying, Pete, that withdrawal and that apathy can often occur quite early. Also agitation and irritation. But certainly as the dementia progresses, you can start to notice more agitation and expressions of unmet need, essentially. And so this is one of the reasons why it's good if we can identify a dementia early, because then we can start to make some plans to try and manage those behaviour changes later.
Yeah, and I think I find just asking the questions, you know, has the behaviour changed? You know, this history is always, where possible, with someone else in the room, with the person who is having the problems. Getting that what we call that collateral history is really vital, and so I don't often label it on, you know, what type of behaviour. I just say, you notice any change in behaviour, and if it's there, it's often recognised and brought up by the other person in the room, about, you know, they've become, you know, geez, they're so short-tempered, or geez, they're getting really agitated and frustrated about losing stuff, or yeah, perhaps maybe withdrawn, like Beck said. And then the last one is a physical decline. So you can have some early changes physically in the illness. There's some research about potentially stride length may change, but I don't think that's something I'm measuring, but that's just something to acknowledge. But it's usually the things you see are sort of more in the later stage of the illness, like we talked about, ability to walk, ability to swallow, ability to talk, and these kind of things. And Mark's put in there about the speech. He just reminded us that really good thing to listen for is when the person can't put their they can't say the word they're trying to find. So like if they're talking about their phone, they're talking about, you know, that's that thing you talk to someone, or the example he's given in his box. Or there's still some controversy going about President Biden. Excellent, I love it. So and Mark's just put in there about vascular dementia is often, there you go, physical signs can be early too. So we've now got stages of dementia frameworks. These are the last frameworks. We've got the inclusion exclusion criteria. We've got the domains, which is helping you take a history. to decide those inclusion exclusion criteria. And the lastly is to try and understand the journey that people are going to go through with particularly in Alzheimer's dementia, which from beginning to end, if you can pick the beginning, you can always pick the end, is roughly about 10 years, just roughly rule of thumb. So we've divided that journey that people go through into 3 stages. So Beck, do you want to sort of talk about the features of the stages?
Yeah, sure. So, I mean, essentially, we have a condition called mild cognitive impairment that we will talk about shortly. But stage 1 dementia is where the person is still really able to function fairly independently. And our mantra in stage 1 would be dignity through independence. So they might exhibit some signs of short-term memory loss. They might require some extra mechanisms to sort of help them manage at home, but essentially they're still able to manage at home by themselves with a bit of extra help. Stage 2, we start to have escalating care needs. This is often where you start to notice more of the physical changes. So people might be having increased risk of falls. Incontinence can start occurring, and certainly in my experience in the geriatric side of things is this is often where families really struggle to be able to maintain somebody living at home. So the mantra in stage 2 is dignity through safety, and so safety concerns become more evident. And at this point, we start often to see that transition into residential aged care. And then stage 3 is dignity through comfort, because people at this point are now starting to have quite significant physical changes. They're requiring a lot more assistance, much less autonomous. And sometimes at this point, sort of at that crossover between stage 2 and 3, that's often when the behavioural changes really escalate as well. By the end of stage 3, which is where we're entering that more terminal phase, then things generally will start to settle in terms of the behaviours, but the physical changes will start to take hold. And ultimately, as we've said, dementia is a terminal condition.
And then if you put all that together, we've got a slide here, and at the top you can see the stages, and on the far left we've got what we call pre-dementia mild cognitive impairment, and we're going to talk a bit about that in a second. So they're the 3 stages Beck just talked about, and then in the middle you can see we've got the 5 domains, and it's not entirely accurate in this slide because we couldn't quite make it all work, but just generally function decline and physicality generally do they all progressively get worse over time. May not be in a straight line like it is on the graph, but that's to signify that things get worse over time, which we've talked about tonight. Mental health symptoms generally fluctuate. That's why it's given a wavy sign. And the behavioural changes, while you might see some early changes in the MCI in the stage 1 phase, generally also get worse over time, but the graph's going up instead of down. So just forgive us for that issue. We couldn't all make it work. But what we did want to try and show you is, like Beck said, it's in that late stage 2 into stage 3 where all those lines are intersecting and the graph looks very messy. Well, that's a representation of life, that generally people living with dementia in that stage of their journey, life is chaotic. They're really struggling to maintain safety at home, and the family is generally really struggling despite potential care being put in place. And this is generally when we're seeing people transitioning into an aged care facility.
Yeah. Sorry, I'm just looking on the chat. There's two comments. In terms of driving and dementia, that is a huge, broad thing which we would love to talk about, but I'm not sure we're going to have enough time today.
Not tonight. We are going to cover it later, though.
Yeah, we will cover it a bit. And as Mark said too, that slide's a little bit interesting. Not all mild cognitive impairment will go on to develop a dementia, but generally Alzheimer's dementia will usually always have a phase of mild cognitive impairment before the dementia starts. So we'll talk about that.
Yeah, that's just coming up now. So the driving and dementia will be covered in detail in webinar 3 and also a little bit in webinar 2. So John, we'll just have to tease you there and you'll have to hang on for that. So the spectrum of cognitive change. So this is a graph to just try and show you a little bit about potentially what people might go through to try and sort of figure this out. So of course, it's not linear and doesn't always go in a stepwise progression, but it's a good, you need to have like a framework in your head to try and understand this more complex stuff. So this is a sort of simplified version that you can sort of hang your hat on, so to speak. And normal aging, you might have some slight slowing of processing, but your function's still intact and you're still doing everything you want to do in your life, even though it might take a little bit longer. And then you can have this thing called subjective cognitive impairment, where you as the person think, oh, geez, my memory's not as good as it used to be. But when I go to Beck and I say, have you noticed any changes in my memory? Beck says, no, Pete, you're completely fine. There's nothing wrong with you. Stop being silly. You're just being paranoid. So that's reassuring. That's good. But then the next step is where potentially you might then move on to actually having changes where Beck goes, geez, Pete, you're forgetting some of these slides and you're not as good as you were like 12 months ago. And that would be, an objective person looking at my changes in cognition. But my function is still pretty much preserved. So like I might, I'm shopping, but I might need to carry a list with myself now. So I might have a few little sort of tools I've got in my toolkit, but I'm still pretty much, my function's preserved. And then if you do have an MCI that is going to progress to dementia, you also have a significant change in function. And then you end up with a possible diagnosis of dementia, as long as you don't have the exclusion criteria. So there's a bit of a idea of kind of understand how this might progress, and how people might present to you and where they might present to you in that journey. And these are the slides on mild cognitive impairment. So I think we've already talked about this, Beck, haven't we? We said you can't, so basically what we're saying here is you've recognized that there's a change in cognition. Again, it's usually progressive and gradual onset, but there's a preserved ability to perform normal daily function. But these changes in
I would say with the mild cognitive impairment, it's not necessarily progressive. So, the next slide will show that, in fact, often the mild cognitive impairment will, here we go. Yeah, so with mild cognitive impairment, we do know that a significant proportion of mild cognitive impairment will stabilise, and in fact, a certain number of mild cognitive impairment cases will actually revert to normal. However, there is still a significant proportion, so about 10 to 15% per year, who will go on to develop a dementia. But that does suggest that at 5 years, 50% of people will not have gone on to develop a dementia at that point. So depending on the cause of the mild cognitive impairment is going to determine whether or not this person does go on to have a dementia.
And it's pretty broad, isn't it? The different things you can cause MCI. There's lots of different
things. That's right.
Yeah.
That's right.
So that's why in this slide here we've called it pre-dementia MCI. So if you're part of that 10 to 15% that progress, then that's what's going on. So the other take-home message here: if someone does have mild cognitive impairment, then you need to watch them really closely, because you want to see what's going on, whether they're going back to normal, whether things are stabilizing, or perhaps things are progressing. And there's lots you can do in that phase. In fact, just about everything you're going to do in terms of treating dementia, you can also offer to someone in MCI. So that's an important principle. So how do we diagnose dementia? Well, we've talked about the basics there, but this is just to remind you that, like Mark was saying, listening or history taking is 80% of the gold here. And hopefully at this stage in your training and your journey, you've worked out, and as GPs, that this is pretty much all general practice, and that examination is very useful to maybe rule out some other stuff or to back up what you're thinking. And investigations are also doing the same thing, but most of the stuff you make is on history. So here's just a reminder of the inclusion criteria. Gradual onset of progressive change in cognition. It's not just memory, it's the realms. So all those other things of cognition that you're looking at. It has a interference in function, and it can't be explained by your other causes listed in your exclusion criteria. Right, so we've got a video we're going to show you in a second to have a bit of fun to demonstrate this to you, but sort of cues and clues, we've sort of talked about this a bit, haven't we, Beck, already?
Yeah, I think so. Having said that, I do like that concept of says a lot to say a little. You know, when a person comes and talks around a topic, or really you ask a question, they don't really give you the answer, but they've said quite a lot at the same time.
Yep.
The head turning sign is also really interesting. You'll often get that with teenagers who come in with their parent and look to their parent to answer the questions, but also people who are experiencing cognitive impairment will often do the head turning sign as well. And I like the head shaking sign, which is the family member in the background who is disagreeing with what mum or dad might be saying.
Yeah. And the empty talk is sort of the poverty of speech that I talked about earlier, which we'll talk about in a second. So how to start the conversation? Well, sometimes people come to you saying, I'm worried about my my memory or thinking, or maybe the family comes in. But you can certainly ask questions. I try and ask these questions on my annual 75-year-old health assessment. I do them when people come in for their annual driver's license renewal. And yeah, you got to kind of keep it broad, and you don't want to be too pushy with this stuff. People can get their feathers up pretty quick. I think you find that too, Beck. People can get a little bit like a little bit back.
No, I mean,
but yeah,
it's definitely sometimes, but often people will sort of take this as, you know, fairly standard questions. Certainly if they've got nothing that they're worried about, then they're usually quite happy.
Yes.
And you know, it's like advanced care directives. We're always very worried about it, but actually often people quite enjoy having an opportunity to talk about it too.
It's true. You get varied responses, and I think the take-home message here is do it often, and then you get to see what's sort of normal and what's very abnormal. So sometimes the people are very don't want to talk about it at all. To me, that's a bit of a red flag, because if you don't have a problem,
a bit cagey.
Why would you be worried about it?
Yeah.
So talked about that. Right, let's meet a case. So this is Anna. So we've made this case easy because we're teaching, and it's easy to teach this stuff with an easy case. so we take the feedback that this might not be so straightforward for you in general practice, but this is an opportunity for us to demonstrate some core principles for you. So Anna's 75. She lives alone and is well cared for by her daughter who lives nearby, whose name's Sophie. And she's come in today for her flu vax. And she's got a pretty simple past history of blood hypertension and osteoarthritis, and she's only on 2 medications. How good would that be, Beck?
Yes,
so,
that's nice.
Yeah. So, like I said, she's come in to visit her GP for the flu vax. So Sophie's come in with Anna. So the first question, Beck, I have for you: when the daughter or the son or the child comes in with their parent, what's the first thing you think?
Well, I think this could take a long time, and that's okay, but it's always a bit of a flag too that obviously they have some concerns, and it's really important to take that seriously. And I think, you know, certainly we'll see how Dr. George handles this, but, you know, that being the case, you can always listen to the concerns and then ask them to come back for a longer appointment as well, I think.
Mark thinks that Sophie's brave. So I also think that I love it. I love it when the family comes in, because it's just an opportunity to learn more about your patient, and you know, it's a golden opportunity. So yeah, it may take a bit more time, or it may be time to get them back, you know, but sit up and take note, because there's usually something going on that you need to listen to. Now, so we're going to do this video. So just grab a pen and a piece of paper. Hopefully you've already got that, or your phone, or wherever you take notes, your computer, whatever, and just start jotting down whether you think Anna has any of the inclusion or exclusion criteria. And we'll watch this video together.
Hello.
Hi, it's good to see you.
Yeah.
How's things been going?
Look, I've come about the flu injection. I think I'm a bit late, am I?
You are a little bit late, actually.
Oh.
Yeah, I was wondering, we sent out some reminders. I thought maybe you didn't get the reminder for the flu.
I can't remember getting one, no.
Yeah, well, that's great that you've come along
Yeah,
today.
yeah.
I haven't seen you for a little while. How have things been going?
Cutting back a little bit. You know, my garden was fairly big, and I'm just sort of downsizing a bit on that, because although I still love it, it was getting a bit much for me, so I'm cutting back on that.
And I just had a look through your file before you came in and noticed that your blood pressure medication were due a little while ago. Have you still been taking your tablets for blood pressure?
I think so.
Yeah, you take them in the evenings, Mum.
Oh, do I?
Yeah.
Right, yes, okay. But I've run out, have I?
Well, the prescription looks like you should have run out a little while ago if you'd been taking them regularly.
Oh, right. Perhaps I miss some sometimes. I'm not sure.
Well, it can be hard to remember, and there are things that we can talk about that might make that easier for you.
Right, okay.
Was there anything else that you were concerned about at this stage?
Well, we just have had a little bit of a worry with the memory loss, like forgetting to take the pills, which we've just heard now. There's been a few incidences of leaving the stove on overnight, not realising that you turned the stove on.
I don't remember that.
No, I know, and that's the thing. There's been a couple of things that you know that you don't remember. Yeah. I don't know if that's normal at this stage, at age, but I just thought it might be worth a check
on some of those things.
Yeah.
In a moment, I'll take you around to see our nurse, and she can give you the flu needle, because that's the main reason why you've come today.
Yes.
Yeah.
And I'll ask Jane to also check your blood pressure and weight, like usual, just to make sure that everything's going along okay.
Right.
One of the other things I'd like to ask.
So we'll just stop there. So just in the chat questions, just start typing down some of the things that you picked up in that short vignette around cognition and other stuff we've been talking about today. Anything you think has been worth noting in those few minutes? Rebecca, I can't see you, so you're still there though, aren't you?
I'm here.
Yeah, you're
I
still
can't.
there.
Oh, hang on. Let me just see. No, I can't see anyone chatting.
No one's chatting. Come on,
Do
get
you
out.
want me
Come
to
on.
give you my thoughts?
No, come on, give me a go. Oh, one new message. Here we go.
Forgetting to take her usual meds, script run out. Correct. That's
Good.
great. Yeah.
So that could be a memory problem.
Yeah.
Come on, I know there's more than that. Mark, you're not allowed to answer. You're banned. Not being aware of the flu vaccine reminder yet.
Fun.
Medication and timing. Yes, so that could be that she's again a memory thing, and then not taking her tablets is something else.
Yeah, and then the safety concerns of the stove. That's right.
Yep.
I think she's also been cutting down on her gardening, hasn't she? There's that sort of indication that maybe.
Oh, you have to wait.
There we go. Yeah. Ooh, sorry, I'm a bit too speedy.
Yep. And what about her speech? Did people notice? How would you? Did anyone pick up that maybe her speech was maybe a bit different? Someone
uncertain with the flow of
she did have
conversation.
A
there we go.
She didn't she? And she just didn't quite have the same sort of like richness and the amount of words she used. And oh, I'm cutting back. Yes, cutting back. Yes. And it may be something or it may not be something, but it's just, it's not the same as, the rhododendrons are getting way out of hand and I can't mow the lawn anymore. And that massive tree in the front garden, that's way too big for me now. That's different to, oh, yes, I'm just cutting back in the garden. So that could be something. Yeah, she was a little bit sort of, a bit put off by the fact that she left the stove on. Whereas
I like the response from Sophie. Yeah, I know.
If I left the stove on, I'd be like, oh my God, that's terrible. God, that's really no good. But she didn't like that. So that might be something there too. So well done, everyone. That's good answers. So collateral history. So get consent. Maybe as Mark said, you can get the patient in the room next door with the nurse. It's good to have a talk to Anna. So let's have a listen to what Anna's got to say. So again, write down some things from Sophie. Write down some things.
So it's great that you could come today, and I really appreciate you being here because it helps to make my job so much easier. It sounds to me like you're noticing a bit of a change with your mum. So if we think back to perhaps how she was a year or so ago, what would be some of the things that perhaps are different between now and then?
She was certainly a lot more active a year ago. She was doing a lot more around the house, doing a lot more in the garden, going out to her bridge a couple of times a week with her friends. She doesn't do that as much. She sort of is getting more fearful of leaving the house, I think. Maybe it is that she's just feeling more frail, I don't know. But she is doing things like turning the stove on and not realising that she's done it and leaving it on overnight. As she mentioned about her gardening, like she actually abandoned half of her garden, which was quite an unusual thing for her. So, the medication, I didn't know that she wasn't taking her...
blood pressure.
Yeah, for the medication. So there's a few things, and I think she's generally okay, but there's just a few things that I'm concerned about because, some days I come in and she hasn't even dressed, whereas she's always been very meticulous about, looking good, and she wouldn't leave the house not dressed, so it's out of character. That's my main concern is that she used to be very busy and now she sort of slowly seems to be withdrawing, but she's denying that. Okay, so she's saying that she's okay, but...
So you're seeing one thing and she's saying something else?
Yeah.
Which...
Okay, so in the chat box, write down what are the functional changes that we've got there from Sophie. Now, people writing down no one's writing anything down.
I can't see much. I think I'm just mindful of the time. So I wonder if we should...
Standing, gardening, withdrawing.
Yeah.
Great. Okay, yeah. So that was a really good functional history that we got there. So
I think you always get an amazing amount of history from the family. That's extremely important. Wherever you can, see if you can talk to, you need to get consent.
Yeah.
But talking to the family makes a huge difference. It can be either very reassuring or it can be really quite revealing.
Yeah. Okay, so we've got 10 minutes. Let's bring it on home, Beck. So we've got the history. We've got a collateral history. We've got quite a lot of clues about cognition just talking to Anna. But we want to try and back up some of our get a bit more information about cognition, and we think it's a good idea to do a cognitive assessment tool. So there's quite a few on the screen there, and I guess some take-home messages for you there is previously we talked about that these tools aren't diagnostic, so that's an important principle. So the other thing is that they're not screening, so they're not screening tools like a mammogram screening or an FOBT screening. They're assessment tools. So we don't do them on everyone. They're much better in terms of giving you information on someone who is presenting with cognitive change. And the other word we use there is try not to call it a test, because if you call it a test, that makes people nervous. So we try and use the word tool. So which one do you use? Well, that depends on the person sitting in front of you and also a little bit about it on the person delivering the tool. So as the person yourself, you want to make sure that you're comfortable and you're knowledgeable about how to deliver that tool when you've had the training. And then in terms of picking the right one, the person sitting in front of you, that's also really important too. So, for example, the mini mental state examination requires a certain amount of education. So you're asking questions like counting backwards from 100 by 7 or spell the word world backwards. So you need to have a certain proficiency of maths and English to be able to do that. So you need to know, whether the person finished school or how educated they are. And you need to know whether English is their first or second language. So the RUDAS is one you can use for someone whose English is their second language. For someone who is Aboriginal or Indigenous, you may consider to use the Kika, which there's both a rural and an urban version. And then there are some other ones. There's a mocha, which you need special training for and you can do online. And then the last one on there is called the GP Cog, which is a free online tool that you can go and have a look at, and I'd recommend you do. And that's a good one that I quite like because it's fairly quick. And in the first part, you're asking the person in front of you the questions. And if you get a certain score, then it prompts you to get a collateral history. So that's great because it reminds me to get the collateral history. And it also involves a clock face drawing test, which is a really good.
And I think, as Mark's just said too, it's a really nice idea. For some of them, particularly ones like the mocha, you can use them somewhat as a baseline and then monitor them over the course of time. And so one of the good things about these assessment tools is that they, A, provide your baseline, and B, they can be reviewed over time to see if for any changes. And the mocha is particularly good too, isn't it, Pete? Because it's got, I think it covers several different domains, probably more so than certainly than the mini mental state examination.
Yeah.
A bit more sensitive.
Okay. So that's good. So in other words, we encourage you to use them, but you should use them appropriately, and they don't, they support what your hypothesis of the diagnosis is. They don't make or break the diagnosis. I guess the other thing there is, some people, like in a mini mental state, can score highly and still have cognitive impairment, and some people can score lowly because they're very nervous or anxious and they still might have normal cognition. So you can get false positives and false negatives in these tools as well.
And if you're worried, then that's another red flag, really, isn't it? I think even if they do score really well, if they have a dementia that's not necessarily an Alzheimer's or a classic picture, they might still score very well on them. So if you've got that inkling of doubt, they're also probably ones that you would ask for further assessment, whether that be with a specialist or a neuropsychologist, particularly in a younger onset person, in a younger person, yeah.
So as part of, bedside tests like the assessment tools form part of your examination. So they're pretty standard sort of observations. Which one do you find most helpful out of those ones, Beck?
Oh, look, I always ask for weight. It's interesting, certainly if there's been a change in weight, particularly if there's any weight loss, that can certainly signify that there's potentially that they're not eating for whatever reason, and that can be a bit of a red flag. And I think also a focused neurological examination can be really helpful as well, both in excluding things, but also looking for other sensory impairments, so checking for hearing loss, checking vision, checking for peripheral neuropathy and that sort of thing, because all of that has a cumulative sort of effect, doesn't it?
Maybe Parkinson's signs too, yeah.
And yes, thank you. Yeah.
Yeah, and then the investigations are pretty straightforward. On my practice software, if I put in the word dementia in my practice software program, it actually spits all this out for me, which is nice. Basically, this is part of your exclusion criteria that we talked about earlier. The imaging of the brain recommendation is a CT brain. So you don't need to do an MRI. They're not always accessible and they can be very expensive because the CT brain is to exclude like a bleed, intracranial mass, hydrocephalus, something like that. They're not. It's not to diagnose a dementia. You need quite specialist, expensive tests to do that, like PET scans and amyloid PET scans and those kind of things.
And Mark's just written there. He does tone, gait, power, coordination. I think that's really good. Thanks, Mark.
Yeah. Yeah, there's some extra tests on the side there you can do too, you know, if you feel like they're warranted and needed. So
Pete, can I just make one comment? Sorry, you don't actually need specialist tests to diagnose dementia. The diagnosed dementia is syndromic. If you want to try and differentiate the underlying etiology of the dementia, then you may need to do so. But most of the time, we're still doing it clinically.
yes, thank you. That's an important point to emphasize. That's right. So what Mark's saying is, if he orders a amyloid PET scan or something like that, it's to try and mainly to work out what sort of dementia you're dealing with. So with Anna's results, she has gradual onset of cognitive impairment. You've seen that. It's progressively getting worse. It's impacting function, and there's no indication of depression on your history. And also you do a geriatric depression scale, which is normal. Her cognitive assessment tool you choose is the MMSE, which scores 22, and she's got an abnormal clock drawing test. We've got an example of that on the screen there. Functional assessment, you guys picked up pretty good. Nothing on a physical exam. Investigations all came back normal, and she certainly has quite concern from her carer. So at this stage, you need to kind of make a bit of a call. And hopefully we have got to the stage now where you would feel confident to make a provisional diagnosis. So you may need, so we've made a bit of a flow chart for you about what this might look like. So, and this is our last slide, Beck, right on time. So it's taken multiple visits potentially, well, usually does with me, 2 or 3. You know, a person's come in, raised concerns by family, and you've taken your history, collateral history, you've done your functional assessment, cognitive assessment, physical exam and investigations. And
can I just say, Pete, just sorry to interrupt, but I do think it's really important to stress here that is one of the fantastic things about being GPs, is that we're very well placed to be able to see these people over time, have several visits. You know, there's now an item number for, you know, an over 60-minute consultation too, isn't there? And so, you know, you really can get somebody back and spend quite a significant amount of time with them and their family. So yeah, I just wanted to make that.
Yeah, absolutely. So you ask yourself, are the concerns likely to be mild cognitive impairment or dementia? And if you think no, then there is stuff you can do. Now, we haven't gone into management today, so I'm going to skip through that slide pretty quickly, because that's the next webinar we're going to do next time, is about management. But you should, you know, review them as a minimum. And if you do pick up a cause for their cognitive change that you don't think is a dementia, then you obviously treat that. So if you think, yes, there is MCI or dementia, then can I make that diagnosis myself? Well, if the answer is no, then contact Mark or your colleague in the area and get some help. And that's okay, especially when you're doing this work in the beginning. And it could be because it just doesn't quite all add up, or there's lots of chronic diseases and you're not quite sure if there's something else going on. Maybe they're quite young, maybe they're under 65. Maybe they've got some atypical symptoms and there's some delusions going on that you can't quite make sense of. Or there's multiple complex comorbidities like I talked about. But you can still start treatment while you're waiting for that specialist referral, because they do take time to get in. And again, we will talk to you about what brain health interventions mean in the next webinar. If you can feel confident to make the diagnosis yourself, then communicate that and start your care of that person. And again, the next webinar is going to be all about the right-hand side of this screen. It's about the care of someone, making the diagnosis and the care of someone, or what we call post-diagnostic care with mild cognitive impairment or dementia. So, to end with the beginning in mind, Beck, dementia is more than a memory problem.
Sorry. Indeed, indeed.
Cognitive assessment
Sorry, I
tools.
was just seeing here. Sorry, Pete,
Oh,
just before you end with the beginning, we have a question saying if they're less than 65, can they still be referred to Jerry's? I think generally that would be something that I would be referring either to neuropsych or to neurology. I don't know. I suspect different regions do things differently.
Mark, do you want to answer
But
that?
that's
You've just been called a Jerry, by the way.
oh,
I'm sure you
That's
won't.
okay. I don't mind being called a Jerry. My children refer to me sometimes in that same terminology, just as it is. Certainly in the Victorian CADAMS clinics, anybody under the age of 65 is more than welcome, and we expect to see those. The CADAMS clinics in Victoria are diagnostic services for all sorts of cognitive impairments, so that's not a problem. In other states, and I'm not sure whether that question was coming from New South Wales or not, I'm not so clear, but if it's a formal memory clinic or cognitive assessment clinic of some sort, 99% of the time they'll be more than happy to see somebody under the age of 65. That is now part and parcel of the common presentations of cognitive impairment.
I think it's quite regional, isn't it?
It's right, yeah, know your area, absolutely. And then the last point that Beck emphasised so beautifully is that you are perfectly placed to diagnose and manage this condition, and hopefully we've convinced you. And if we haven't convinced you yet, then you better come back for part 2, and we'll convince you there. So check this out. So particularly on the right-hand side, there's a link to a podcast series put on by our organisation, DTA, Driving and Dementia. There you go, John. There's straight off the bat that one's there. So that's pretty cool. There's 3 series now you can listen to in your car on the way to work, better than listening to the news, which is all depressing right now. And lastly, we really want you to do the survey. And Jade's put a link up there. Thanks, Jade. Or use the QR code on the screen. Thanks, everyone. So that's been a great evening. I'm happy to stay online for a few more minutes. I'm sure Beck and Mark are if anyone's got burning questions.